Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalen, professor and head of the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus. I'm your host for our program tonight on lower extremity, knee, foot, and hip problems. The success of this program is very dependent on you, the viewer, so please call in your questions tonight or send them in ahead of time to our email address, ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Taylor Pazuk, an orthopedic surgeon with Orthopedic Associates of Duluth, Dr. Sandy Stover, a family medicine physician and faculty member at the Medical School Duluth, and Dr. Philip Thomas, an orthopedic surgeon with Essentia Health. Our medical students answering the phones tonight are Sydney Clausen from Stewartville, Minnesota, Jessica Crossan from Hugo, Minnesota, and Wyatt Windhorst from Alexandria, Minnesota. And now on to tonight's program, lower extremity, knee, foot, and hip problems. And the first question is for Dr. Stover. Dr. Stover, would you tell us how you advise your patients with bunions on the feet?
Well, bunions are one of those things that it's really not anything you do that creates a bunion. It's basically sort of what is going to happen because of genetics. There are changes in the foot that start to change the angle of the big toe, and the best thing to do is to give it room in your shoes. So soft shoes, leather shoes that can be stretched, things that help reduce some of the wear and tear and the rubbing on the side of the toe. There are a variety of things that padding, different kinds of padding that can be used. The kind of change that happens with a bunion, it can be corrected by surgery. You can have the toe straightened, but it will recur, so you want to wait as long as possible before addressing any kind of surgical correction for it.
Thank you. Dr. Thomas, do all Achilles tendon repairs go to surgery?
Yeah, that's a great question. I think it's one of those things where Achilles tendons were something that debated in the literature quite a bit, and that we used to sort of fix all of them because the tendon would separate and that would make complete sense. And with the rise of pickleball, we're seeing an actually incredible rise in Achilles tendon ruptures. And I think oftentimes those do kind of get pushed towards the surgery or feel the need for surgery. And there's really good literature out that actually says the vast majority of Achilles tendons don't need to go to surgery and can be treated very well non-operatively. So I think at the very least it's worth a discussion with your surgeon or your doctor, whoever you're working with for it, from the idea of, is this the right thing for you? And there's certainly risks that come with surgery, and there's risks that come from that surgery in particular. So I think they certainly do not all need to be fixed, and some of them it makes sense and some of them it's appropriate.
Thank you. Dr. Pazuk, this question is for you. How soon do hip replacement patients begin walking?
Yeah, that's a great question. I think it's one of the more common questions we get asked about with almost any surgical intervention, specifically regarding the lower extremities. And for the hip, knee, back, anything, really try and get people up moving as fast as possible. So the same day for hip and knee replacements, most of them are done under spinal anesthesia now. So as soon as that kind of wears off and their proprioception and strength is back, we have them walking. Usually that's within a couple hours of surgery. We have really, really good evidence to suggest that early mobilization is not only good for the first 1 to 10 days after surgery, but long-term as well. Prolonged immobilization leads to inflammation all over the body, and it can really delay some of its progress from a rehabilitation standpoint.
Thank you. Dr. Stover, how do major lower extremity joints become infected?
That's a good question. Bacteria generally don't easily get into the joint because there's a lot of protective things, the skin and the joint capsule itself. But it can happen through the blood system sometimes if there's traveling bacteria that aren't caught by the immune system. It can happen if there's an injury somewhere near the knee that it locally gets infected. And there's things like Lyme disease that can create a vector that infects the body that likes to go to joints. But joint infections without a direct injury are less common than ones that have an injury related near the joint.
Thank you. Dr. Thomas, this caller from Chisago City in Minnesota needs a knee replacement, but I'm in my 60s and I'm worried I will need it replaced. Should I wait to get it?
Yeah, that's a very common question we also get as well. I think it's one of those great things that we've reached the point now with sort of advances in technology and how we're doing this, The biggest thing being, I tell everyone with a joint replacement is it's just a resurfacing. Everyone's like, oh, I thought you were going to cut off the end of one leg and cut off the end of the other and then put it all back together. But really, we just take off the arthritis, which is the pain-causing problem of the need for a joint replacement. And then ultimately, what really mattered in the history of where people used to say, oh, you get a joint replacement, it lasts 10, 12, 15 years, and then you need another one, was the piece of plastic we actually put in between those two pieces of metal that allow it to move and articulate. We've come a very long way in a very short period of time where that piece of plastic has become very, very stable and very long lasting. So the most recent literature we have is showing that these joints likely last 25 to 30 years or longer, with the answer really being that we don't know how long they last because they've gotten as good as they've gotten. So I think 60 is a more than a reasonable age frame to talk about a joint replacement. The big thing I always tell patients is that you tell us when you're ready to have a joint replacement. It's not us telling you. So it's when you can't do the things that you want to be doing because of that pain in your joint, if you're starting to lose motion, if you're having issues sleeping, those types of things. But we do total joints in 40-year-olds and say, yes, there's a higher chance at 70, 80, you may need what we call a revision and an additional joint after that. But in your 60s and 70s, there's a very high likelihood that lasts the vast majority of your life, if not the entire thing.
And for some of those younger patients, we have alternative bearing surfaces, ceramic on ceramic, that even last longer than the metal and polyethylene wear. So if that's a real issue for someone, that's just a conversation you have with your surgeon. You guys make a decision together. There's no right or wrong answer to that kind of stuff.
Thank you. Dr. Stover, why do hip fractures increase mortality rates in elders so much? The caller from South Dakota.
That's a really good question, because it's one of the reasons that we really work hard to develop strength for some of our older patients and reduce things that could make a fall happen in a home, like throw rugs, like having shoes that don't fit well. But the issue is that once a hip fracture occurs, there is a longer healing time. So it is a little different than if you have a hip replaced for arthritis and it's a controlled setting. But if you have trauma, there's more swelling and more fracture elements there. And so people are often bedbound longer, and in elders, that's hard on skin, and on the longer you're in bed, the lighter your bones get, the weaker your muscles get, and that sort of feeds itself. And so ideally, people maintain their bone strength as much as they can by walking, and reduce the things that are more likely to lead to a fall. Yep.
Dr. Pazuk, a caller wants to know, does being overweight cause a lot of knee and foot problems?
It undoubtedly plays a role anytime you're talking about putting stress through a joint. It kind of predisposes you to developing something early on in life, but we have really, really good evidence now in the literature that suggests that even if you're, a high-performance athlete or morbidly obese, that doesn't mean you're going to develop arthritis. It just means that you may have an increased risk for it. I think more so than anything else is that there's a genetic predisposition to developing hip or knee arthritis, shoulder arthritis, back issues, things like that. And so while maintaining a healthy weight is good for your overall health and your joint health, it isn't the end-all be-all, and it's something that is very patient-specific and is not necessarily a one-size-fits-all scenario.
And I do think there's reason, there's plenty of folks that come in with bad knee pain and you say, well, your BMI is this level, we got to get a little lower before we talk about joint replacements. And a lot of those folks come in and they've lost 10, 15, 20 pounds. I tell everyone you do 4 times your body weight across your knee joint, depending on your alignment, but most commonly. And so folks that lose 10 pounds end up losing 40 pounds across their knee joint, and oftentimes they come in and say, I don't need a knee replacement anymore because my knee feels so much better now that I'm not carrying that weight across my joint. So that can be the one plus side of that, is saying, hey, let's get a little lighter from the standpoint of what we're carrying on our lower extremities.
Thank you. Dr. Stover, a caller, Luke from Alexandria, wants to know, does glucosamine help?
That's a good question. So there's been some back and forth in the literature over the last 30 years, and I think that's pretty clear it does not cause harm, and I think it's also clear that for some people there is benefit. They feel better with it, but there is not, it's hard to pin down literature unless you guys have seen more recent literature, that there's a specific thing that it does. And I think a good nutrition definitely helps joints. So, and regular activity, keeping the tone of the muscles pretty even around the joint so it doesn't have, too much stress across there. Physical therapists can be really super helpful for that, and for trainers. Yoga is one of the things that helps reduce issues because it evens out some of the pressures across all the joints. And no, I don't do it. I should do it, but I don't do any yoga.
Thank you. Dr. Thomas, this caller wants to know, is ankle replacement too new of a procedure, or has it had a lot of research supporting it?
Yeah, I think that's a challenging thing too, because like many things, and unfortunately this is just the nature of healthcare, is that it's very patient specific. So it's one of those things where if you're the right patient and the right candidate for a total ankle, I think people do extremely well with those. And just like total knees and total hips 30, 40 years ago, we're certainly in the relatively early stages of some of that, but we've come an extremely long way in a very short period of time in terms of the quality of those implants, again, how long those implants last. Big thing with the ankle is how well those implants are fixed. It's much harder than in the knee or the hip. But certainly in the right indication, the right patient, it's just not quite as, with most of the ankle replacements we have now, you don't get the kind of activity level with total knees and total hips that you typically get with a total ankle, but it's still a very viable option versus really the only other alternative for the most part is a fusion. So that's where the bone gets stuck together and you can't really move it anymore to kind of fix that arthritis. So it can be a certainly better alternative than that, depending on the situation and depending on sort of expectations and outcomes.
Thank you. Dr. Pazuk, for you, from Mark in Marine on St. Croix, Minnesota, why does one's knees crack every time they bend?
Cracking, snapping, popping in any joint and or around any joint is very, very non-specific. But it can be secondary to if you have baseline arthritis, you have some osteophytes, or which are just bony projections from your arthritis sticking off, catching different ligaments, menisci, things of that nature. But it's very, very non-specific and very, very patient-specific. But the snapping in of itself, that audible sound, generally speaking, is not a major issue. It's the underlying cause of that snapping that's the major issue.
Thank you. Dr. Stover, Tom from Superior wants to know, what therapies other than compression socks can be used to treat lymphedema, specifically of the lower legs?
That's a good question, and it depends a little bit on the cause. So lymphedema of itself is different than just swelling in the legs, and lymphedema does respond to some of the physical therapy techniques to do some massage to get the fluid moving out of the tissue. The reason that it forms doesn't get fixed by that, so you have to be careful. And that's why compression socks are so commonly used. There are better ones out there than there were even 10 years ago, and so that's something that for people to consider is looking at other options besides the classic TEDs. There are many others out there now that can be more comfortable to wear.
Dr. Thomas, a caller from Finland, Minnesota, asks about bulges on the Achilles. Could they be from fluoroquinolones? Could there be treatment for this?
Yes, I think that depends on where the bulges are located. Typically for folks, they're usually where the Achilles inserts into the calcaneus bone. If that's the case, that's something called a Haglund's deformity. That's a very different type of bulge. If there's thickening of the tendon itself, typically with fluoroquinolones, it's actually a weakening of the tendon, not a thickening of the tendon. So it'd be unlikely that'd be the cause for it to sort of have that sort of balled up formation to it. But there could be partial tearing that's healed and has led to some of that balled up as well. But typically it's right on the heel where we feel that. And that's often actually a bony formation on the back side of the tendon. And it can be quite painful, and then that's, that can lead to a surgery where we actually take the tendon off, cut that bone off, that small kind of extra bone, and then reattach the tendon and essentially do an Achilles tendon repair.
Thank you. Dr. Pazuk, a caller from Hibbing, Minnesota, 76-year-old male with a labral tear in the right hip. Shots have been tried. They haven't worked. Is there anything other than a complete hip replacement that could help?
So I think that's a really, really good question. The idea of labral repairs in the hip have become pretty vogue in the literature over the past 10, 20, 30 years. As we get older, the underlying cause of labral tears in the hip more often is a degenerative process. So again, kind of the chicken or the egg. More often than not, the arthritis led to the labral tear. And so fixing the labral tear in the setting of arthritis is kind of a predisposition to failure. In that setting, I think the alternatives are strengthening the muscle girdle around the hip, physical therapy, things of that nature, occasionally injections in the hip. That's again debated, but outside of a hip replacement from a surgical standpoint, I wouldn't recommend getting your labrum repaired at that age. Again, if you have underlying arthritis. But again, everyone is very different, and this is a question on a piece of paper rather than looking at images and stuff like that. So.
Thank you. Okay. Dr. Stover, Robin in Wisconsin asks, for fibromatosis, on the feet and hands, once removed from the foot already, came back bigger. What's the treatment and how long should one wait?
It's a good question, and that's another one that's, I think we kind of fall back on, you should talk to your doctor about that. They know you best, how big it is, how long it's been there, what other options are there for you. But those kinds of things are often there's some inflammation going on, and addressing what that is may be most helpful for keeping it from coming back. Sometimes steroid shots are helpful, but in the foot they have to be really careful about that because it can impact the gristle of the bottom of the foot. So I would bounce that one back to the individual's physician to kind of look at that and make some plans.
Okay, thank you. Dr. Thomas, from Sam in Virginia, Minnesota, if a knee replacement is needed, but the patient is allergic to metal, how will the patient be able to have this surgery?
Yeah, so typically it's a specific metal itself, and if that's the case, then it's just a matter of figuring out what that metal is. There are some alternatives. Most commonly is the nickel allergy. There truly is a fair amount of debate in the literature as to whether or not that nickel allergy truly exists from the standpoint of implants in the bone, or at least it's extremely rare to have that true nickel allergy versus something like, oh, I wear nickel earrings, then I get a skin reaction. That's very different than putting something in your body. But if that's the case, it's certainly something where, allergy tests, those types of things can be sorted out to say, is there a specific metal that would be tolerated versus not? And there are alternatives, to the standard, what's called a cobalt chrome alloy, which has nickel as its component. That's typically the most allergic metal of the metals in the joint replacement itself. There very, very, very often are other options. It'd be extremely rare that there wouldn't be something available.
Thank you. Dr. Pazuk, this question from Mark, a caller. Are there any newer knee replacement surgeries that are more amenable to running afterward?
So I think it depends. I mean, there are hemi replacements, so either you're replacing the patellofemoral joint or one condyle or the other, meaning the outside or the inside of the knee. I think, it depends on how active you are. Again, harping back to what Dr. Thomas said, the polyethylene that we're using now, which is that plastic spacer between the metal on metal, has really come a long, long way. And while, if you're jumping off 10-foot cliffs every day, you're more likely to wear that out, I think running's a very organic motion. And we put these polyethylene liners through these trials of millions and millions and millions of cycles, and they're not wearing out. And so I would say that the knee replacement, however you have it done, in today's world, the components itself are not super amenable to wearing out because you're running marathons. I think if you're going to do that, I think that's a perfectly reasonable thing to do, and it's just a conversation with your physician regarding the limitations of the longevity of your implants, but I don't think that would prevent you from having anything, or you should seek out something different than a standard knee replacement.
I think the other thing with that too that people often don't understand is that if you, based on what's called alignment, so your hips to your ankles align, often folks are a little what we call bow-legged or knock-kneed, or the medical term is varus or valgus. If you have isolated arthritis to one component of your knee, there are certainly surgeries as well outside of knee replacements, depending on your age. That can be very reasonable options that very high-level athletes have had done, and very high-level performers in terms of impact on their joints. They can buy you 10, 12, 15 more years if it's hey, I really want to run a lot and this is where the arthritis is. There's certain images and things we can get to look at that as well to say, oh no, based on this, I think this surgery save you a total knee for another 10, 12, 15 years, to where your degree of how you hope to run is likely much less in a decade than it is now. So there are potentially alternatives to that as well that oftentimes aren't always looked into. So.
Thank you. Dr. Stover, a caller wants to know, for numbness on the bottom of both feet, what could the cause or causes be?
So the numbness on the foot is usually due to something related to one of the nerves. And so it can be a nerve from the back, or it can be what we call a peripheral nerve. So the little ones that kind of come out and fan out like branches from a tree. And the most common from a national perspective is diabetes. And so if there's numbness on the foot, it's good to just make sure your regular doc has checked that out at some point in time. And there are tests we can do to kind of help tease that out. Tests looking at the nerves and tests looking at some of the other metabolic things that can impact the ability of the nerve to do its job. So numbness on the foot is worth checking out because, to the other question that we talked about with falls, when you don't feel your feet in the same good way, it's easier to have a fall happen.
Thank you. Dr. Pazuk, if a caller from ESCO has very painful diabetic neuropathy And side effects with gabapentin. How about a TENS unit to address that pain or other therapies?
Yeah, that's a painful diabetic neuropathy. I think is a probably a very challenging thing to treat, and again, very patient specific. I think there are a host of medications, gabapentin being one of them, Lyrica, various different trade names that can go about addressing it. And every patient is very individualized based on how sensitive those nerves are because of the microvascular changes that occur in the setting of diabetes. But I don't think there's a one-size-fits-all in this category. I think I would talk to your physician, try a host of different things, and try and get some relief. I think I would stay away from some of the stronger pain medications, of course, but I think exercise and trialing various different medications and or a TENS unit or ice or heat, some variation of that with the advice of your physician is probably what I would do. I don't think there's a one-size-fits-all for that answer, for that question.
Thank you. Dr. Thomas, Bobby from Evolus? Yeah. How do doctors determine what size hip replacement to use and when to replace it?
Yep, so kind of bouncing back from the previous question, I think from the standpoint of when to replace it, that's again the conversation of you tell me when your life's reached the point that your quality of life is suffering in a way that says, I just can't live the life I want to live and do what I want to be doing, therefore I'd like to talk about a hip replacement. And then that's supported by a clinical exam where we move your leg around and see what bothers you and what doesn't. Challenge with the hip, I think that's an important thing I always tell patients is it can get very blended with the back as well, so you want to be certain that you're not misdiagnosing something and saying this is coming from your hip when it's actually a different cause, because the last thing you want is a total hip. Then you get done and your back was the cause, so the same pain is still there, or it's still just as painful, or maybe not quite as painful, but still very bothersome. But so once you reach that point, you say, hey, x-rays, all these things look like it's amenable to hip replacement. Then essentially what we do is we get just an x-ray of your AP pelvis, and we call it a low AP pelvis, so we see a good chunk of your femur as well, or your thigh bone. And then we just do what's called templating, and we have software that we use based on the implants that we're using. And all that software is we basically put that up on the screen and we size it in our office and we set all that up ahead of time essentially, and then based on that, when we're in surgery, we have a rough idea of what those implants are going to be, and then we just do, it gets kind of complex from there, but we basically size things based on the size of your femoral head. So the head on that femur that goes into the cup and ball, basically the ball part of that, we measure that size and we get close to about that size for the cup, and then for the stem, we just use a series of what are called broaching, where we start with a very small stem and we get bigger and bigger and bigger until it essentially fills up your femur more or less, and that's usually within one size of whatever that templated size is.
Thank you. Dr. Stover, this caller from Duluth wants to know how to tell the difference between sciatica and arthritis.
It's a good question. So sciatica is a term we use for when there's a nerve irritation or inflammation that causes pain to shoot down the leg. And so it tends to be kind of a zinging pain. Arthritis tends to be more in a joint, but if it's in the back, it's in the joints, the many joints that are in the back, it can also cause some compression on a nerve. So you can have arthritis and sciatica, or just arthritis. So that teasing that out, there's a number of different kinds of physical exam maneuvers, but also some tests like EMGs, electromyograms, and things that can help tease out which thing is it that's causing the pain.
Yeah, they're not binary. They could very much be, in conjunction with one another, especially when it comes to the back. When you start to get arthritis in your back, it's in close proximity to the nerves that make up the sciatic nerve. We, in general, refer to as sciatica, but that's a conglomeration of nerves from your entire low back. And so it can be compressed at any one of 5 levels and cause that pain going down the leg. True pain in the lower extremity, the hip or the knee, is generally speaking pretty focal to that area. It can radiate in some capacity, but not necessarily shooting all the way down the leg.
Thank you. Dr. Stover, this is perhaps a brief question. Is there a role for magnesium to help with conditions of the lower extremity?
Mixed thoughts about that one. There's not a lot in the literature that specifically supports magnesium, unless you guys have read anything. So there are other reasons magnesium is helpful, but specifically for pain in the legs or issues in the legs, I haven't seen anything in the literature on that.
Restless leg is the only thing I talk to some patients about, and then I always tell them just be careful which magnesium you're getting, because magnesium citrate is for your GI, and you will not like the results of that.
Loose stools.
Yes, exactly. Versus magnesium glycinate is the typical one, and that can help with sleep as well. So that's pretty much the only thing from a lower extremity standpoint.
This question for a short answer, Dr. Pazuk, and with time available, an 84-year-old caller from Two Harbors. Both knees were replaced, no pain, but one leg is angulated now. Should the patient be worried or be seen?
If the main issue is cosmetic and not pain related, I would say no, as long as it's not causing a functional debilitation. With that being said, it would very much take an examination to delineate exactly how angulated that knee was, if in fact that happened, before, after, or during surgery, or, I think that's very much a conversation between the patient and their physician, especially in the setting of no pain and a clinically kind of irrelevant exam.
Well, thank you very much. And I want to thank our panelists, Dr. Taylor Pazuk, Dr. Sandy Stover, and Dr. Philip Thomas, and our medical student volunteers, Sydney Clausen, Jessica Crossan, and Wyatt Windhorst. Please join Mary Morehouse next week for a program on mental health and couples. Thank you for watching. Good night.